Hello. Today we're going to briefly discuss how to assess your patient for delirium utilizing the Confusion Assessment Method for the ICU, otherwise known as CAM-ICU. In order to accurately identify patients as delirious, we need to consistently test our patients. It's not an acceptable option to use patient behavior as your assessment piece. It is very easy to identify hyperactive delirium patients, but we often under-identify the hypoactive delirium patient. We start off by assessing level of consciousness. In order to do this, we must utilize the Richmond Agitation Sedation Scale, or RASS. At deeper levels of consciousness, such as a RASS of -4 or 5, it is difficult to test them because the patient is not responsive. In this situation, we do not conduct the CAM-ICU and refer to the patient as unable to assess. This should occur very infrequently. Once you've determined that your patient is testable and has a RASS of greater than or equal to -3, you move on to assess content of consciousness. To assess content of consciousness, you must follow the CAM-ICU algorithm. Start with feature 1. Has there been an acute change from mental status baseline, or has the patient's mental status fluctuated in the last 24 hours? To answer the first question, we must take into consideration the patient's pre-hospital mental status. You can get this information from family, friends, or the H&P. If no one is available to help establish what the patient's baseline is, use critical thinking skills. If the patient is young, which can be considered less than 65, and is admitted from home with no documented neurocognitive disorder or history of stroke, then you could assume that the patient has a normal baseline mental status with a RASS of 0. If the patient is older, has documentation of a stroke or dementia, or came from a nursing home, then you can assume that the patient's pre-hospital baseline may not be a RASS of 0. Always use the patient's baseline mental status for each successive CAM-ICU assessment. If your patient has not had a change from their mental status baseline, and their mental status has not fluctuated in the past 24 hours, then you can stop, and note that your patient is CAM-ICU negative and not delirious. Now remember, alteration in mental status includes those that are chemically induced by IS, including fluctuation due to titration of sedatives. This is not the patient's usual mental status. So, if the patient has had any fluctuations in their RASS during the previous 2 shifts, they have had a fluctuation in mental status, and you would move on to feature number 2. Feature number 2 assesses for inattention. When completing this assessment, say to the patient, I'm going to read you a series of 10 letters. Whenever you hear the letter A, indicate by squeezing my hand. Read the following 10 letters in a normal tone, loud enough to be heard over the noise of the unit, at a rate of 1 letter every 3 seconds. Remember, patients with ICU-acquired weakness or other neuromuscular diseases may require more time to respond or indicate response with another method such as eye blinks or finger taps. When scoring the patient, errors are counted when the patient fails to squeeze on the letter A, as well as when the patient squeezes on any letter other than A. If a patient has any movement or eye opening to your voice, but does not squeeze at all or does not stay awake long enough to squeeze for more than 1 letter, then this patient is obviously inattentive, and you move on to feature 3. This also applies to a patient who is agitated with a RASS of +1 to +4, and therefore not participating in assessment or comprehending your instructions. If your patient makes less than 2 errors, then you can stop and note that your patient is CAM-ICU negative and not delirious. If your patient makes more than 2 errors, proceed to feature 3. Feature 3 asks you to once again identify the RASS level your patient is currently at. If they have a current RASS level of anything other than 0, which is alert and calm, they're considered CAM-ICU positive and delirium is present. If they are a RASS level 0, then proceed on to feature number 4. Feature 4 is where we assess disorganized thinking. This is often where we identify those patients with hypoactive delirium. They've been calm and cooperative, not demanding much attention, but when really tested, they have disorganized thinking and are delirious. Patients are asked to answer 4 questions as well as follow 2 commands. Begin by asking question number 1. Will a stone float on water? Give them time to think about it and respond. If at any point in time they make more than 1 mistake, you may stop assessing them and identify them as CAM-ICU positive and delirium is present. If a patient cannot move his or her arms, or is blind score solely on the questions and skip the commands. In that case, feature 4 would be present if the patient misses more than one question. Though it is challenging, you can perform the CAM-ICU on dementia patients. The features of delirium are identifiable even in the presence of dementia. A good question to ask the family is, do you think he or she could do this test at baseline? If the family does not believe the patient could be tested, then the patient is considered unable to test. In order to facilitate testing on all patients, the RAS and CAM-ICU algorithms will be hung in each patient room in both the ICU and the IMCU. This tool will help prompt you through the delirium assessment process. All ICU and IMCU patients must be assessed for delirium at least once a shift. I hope this has been helpful for you. Thank you.